Another endpoint I want to talk about too, just because we've been used to thinking about this with our SGLT2 inhibitor trials, is the KCCQ. And, you had a 1.6, point improvement, placebo versus the placebo arm. And, reality is that's pretty comparable to what you see in these large global mega trials. Some of the exclusively, hospitalized trials, the smaller trials with SGLT2 inhibitors, for example, can get larger KCCQ improvements. But put that 1.6, point improvement in KCCQ in context for us.
I agree. I think it's consistent with other evidence-based therapies that form our guidelines. The 1.6, as a reminder, is an average effect across a broad global population. So some patients may have significantly greater health status benefits, some may have less. Furthermore, the 1.6 is on the absolute scale, and many patients in these trials had mild symptoms of heart failure, and so their health status may not be significantly impaired at baseline. So we wouldn't anticipate large magnitude absolute improvements in health status. It's difficult to improve an already well person. So overall, I think this is in keeping with prior evidence and prior trials. We are conducting additional analyses that will be presented at the HFSA meeting related to a breakdown of additional domains of the KCCQ and a responder analysis, assessing who are the patients who develop maybe clinically significant improvements like 5, 10 point improvements in the KCCQ, and was that differentially observed between arms?
I look forward to seeing those data, and again, very well said.
Yeah, I think a lot of us, are still trying to do analyses from the SGLT2 experiences. I was fortunate enough to be involved in the leadership role with the Credence and the Canvas programs, and we're now being able to unravel some of the potential mechanisms of the treatment effect with the SGLT2 inhibitor class because of analyses of biosamples. We're looking forward to doing the same in the FLOW trial. So perhaps some translational research will help us better appreciate the mechanisms by which these classes of drugs are showing the remarkable benefits on cardiovascular outcomes, on kidney outcomes, and as you've seen in FLOW, on all-cause mortality with semaglutide compared to placebo. And then the other thing that is being done through a consortium of academic partners is starting to aggregate the data across all of these trials. And we're going to be able to learn a lot more from patient-level analyses of these individual trials in systematic reviews about potential effects in specific subgroups and patient populations. So I'm really excited about that work that's ongoing right now.
What we have essentially produced so far from a data perspective is that you induce regression of hypertrophy, you induce regression of LV wall thickness, you improve left atrial size, you decrease intramyocardial edema. And so all of these are favorable changes. When we look at absolute measures of fibrosis, we see that they're stable over time. But the complex part is that these measures of fibrosis assume that your intracellular and extracellular compartments are behaving in a proportional fashion, which is not actually true. You could influence one compartment and not influence the other. And as such, we use metrics that index these measures of fibrosis, such as indexed ECV, which was improved in patients who were on Aficamten. But I think what we need to do is we need to look at the FOREST-HCM trial, which is going to produce MRI data over 5 years, to try and understand what happens to replacement and interstitial fibrosis over these 3 to 5 years of treatment with Aficamten.
There are a lot of great trials at ESC in London I'll just pick 4 of them to go through, but really it was an incredible meeting with lots of great data. Let me start with the Fine Arts HF trial. This got a lot of attention, deservedly so. This examined Finerenone in heart failure with either mildly reduced or preserved ejection fraction, and the overall trial was positive, showing a significant reduction in heart failure-related events. So this was welcome news. I think now we have another treatment for heart failure with preserved ejection fraction. A question that did come up was how this might have compared with spironolactone. Of course, there's no way of directly answering that, as this was a placebo-controlled trial if it was Finerenone versus placebo. And there was a slightly increased risk of hyperkalemia with Finerenone. This had been a concern as well with spironolactone. Spironolactone was studied in the TopCat trial with HFpEF as well. Now, that trial wasn't positive, strictly speaking, but on post hoc analysis, if you were willing to go there, if you excluded some countries where it looked like there was just some shoddy research going on, it looked like in post hoc subgroup analysis in the countries and sites that were behaving properly and adhering to the protocol, that spironolactone did work. So I'm sure this will be the topic of many symposia and debates.
So we kind of think about lipoprotein A as a cholesterol-containing particle with this extra portion of lipoprotein called ApoA, which is genetically determined. And so as a result of that, we have looked at multiple studies where we see that higher levels are associated with worse outcomes. We know there's ethnic variation, and so, people of Black ancestry tend to have higher or African ancestry rather tend to have higher levels, and compared to the rest of the world, for example. And so that inevitably, so I'll give you some numbers to think about. So typically we think about 20% of the population having a level above 70. So when you do population studies, you look at above 70 and the curves go off like this and go, wow, look at that. How bad is that? And increase the risk of heart disease. Now, we don't have treatments for that yet. We don't know if lowering it will make a difference. So we also know that your risk of cardiovascular disease won't just depend upon lipoprotein A, but global risk, other factors, smoking, hypertension. So you can add all of that up. So the first thing is we're going to answer the question in 4,000 people systematically 1 year after a heart attack or a diagnosis of coronary disease in 14 countries, systematic approach surveys using the best assays you can to define what the levels of LPA are around the world. So you would think that, for example, that those numbers would be really high in people with a heart attack based on everything else I was going to say. And the answer is that the average LPA level is 32 nanomoles per liter. So basically, but for context, the general population has a level of about 16 nanomoles per liter. That's the median, right? So basically, so the levels are going to be higher in people with coronary disease, but not those extreme levels that you think about. So that's the first key thing.